We're going to talk about telehealth and where it's really still working well, because a lot of us, if you're working in a big box environment where you're in a hospital or a health system where everything is run by reimbursements, there's a sense that, oh, telehealth, was paid for during the pandemic and now it's going away. But it's not. It's growing, and it's growing big. And so that's what we're going to talk about in the first panel. With that, Brandon and Harshal, there's Brandon. And welcome. Yeah, you can just park yourself here. All right. So our morning conversation is, again, continuing this idea of healthcare everywhere. Since most of us know already what telehealth is and isn't, we're not going to go into any kind of elementary discussions, but really talk about what the practical nature of healthcare, telehealth usage is on a day-to-day basis. And so we've got really great panelists here who are going to talk about that. But as usual, you should prepare your questions. Anytime your question pops up, you don't have to wait for permission or anything like that to finish up. But if you have a question pop up, please raise your hand. I'll definitely pull you in. But with that, Brandon, can you go ahead and do your intro and give a little bit of background on the company, and then go to Harshal then.
Sure. Can you guys hear me? Oh, wow, I have to get really close. Okay, awesome. So I usually like to introduce myself with a story about how I got here, because it totally makes sense. I was a PhD student at the University of Utah back in 2013, and I was working on a prenatal care project where there's a lot of pregnant moms in Utah, and so we wanted to find a way to provide prenatal care to these pregnant moms, especially in rural areas. And the clinicians there were like, yeah, what can we do for these pregnant moms who have to travel 2-3 hours for prenatal care, and you don't need that many visits? And so why don't we use telehealth? And that was doing my PhD in biomedical informatics, and so I was familiar with the technology. And they said, "Oh, that's great. You're the technology guy. Go figure it out." And so I was like, "Well, every mom's got Skype or FaceTime, so let's just use that." And then when we went to propose that to the university, they're like, "You can't use Skype or FaceTime. It's not HIPAA compliant, and so you have to use a HIPAA compliant tool." And so I'm like, okay, well, what are the HIPAA compliant tools? And this is 2013. They're like, well, you got this Citrix system that costs $2,000. You got this Polycom system. They have to have a hardware, and you have to have somebody go out to the mom's home and set up this hardware. Does that work for you? And I'm like, that is absolutely not going to work for us. And I'm like, I just need something that's simple and free that's HIPAA compliant. And I literally Googled simple and free telehealth software, and nothing came up. And I'm like, this is 2013. How does this not exist? And so being young and dumb, I said, you know what? It can't be that hard. I'm familiar enough with the technology. Let me just go build something. And so as a student, I built a simple and free telehealth app, used WebRTC, didn't collect any data, made it HIPAA compliant, and we rolled it out in the study, and the providers and the patients loved it. They're like, this is so great. It's so clear. You just click a link, you're able to have a call. And they're like, but it'd be really great if I had a waiting room or a patient queue. And we're like, that's a good idea. Let's add that. And so it's one of these things where I accidentally created a product based upon needs and feedback, to the point that when I finished my PhD, we had a fully built out product. And I'm like, well, this is pretty cool. I went and became a professor at the Medical University of South Carolina. So I moved from Utah to Charleston, and I just released it. And I said, well, we'll see what happens. We throw it out there. Well, a lot of other people had the same question of, where's a simple and free telehealth app? And they found this product, DoxyMe, and it started to grow organically over time. And it was like a side thing for me while I was being a professor, to the point that by the time 2020 came around, we had 80,000 providers on the platform. And we were thrilled. This is great. It wasn't my full-time thing. It was kind of a side thing. But COVID hit, and we went from 80,000 users to 700,000 users in 2 months. And at that point, I knew my life changed, and I said, you know what, I got to go run this company. And so my being a professor became the side hustle, and running DoxyMe became the full-time thing. And so our mission at the beginning of DoxyMe was like, telehealth should be available to all, and cost and complexity should not be a barrier. So we created a simple and free telehealth solution, and we did that, and we accomplished it. And with COVID, everybody had access to simple and free telehealth. Zoom is out there. A lot of EHRs now have it, so that access to telehealth was no longer a problem from a technology perspective, because from a technology perspective, telehealth is available to all now. And as we grew, we've grown tremendous. We have about 1.5 million providers on the platform now. Um, One of the things I noticed was that even though technology is available to all, telehealth is still not used by all. And I said, well, why is that? What's going on? And so my researcher brain started to kind of ask that question, why isn't, even though the technology is available, why isn't telehealth available to all? And as I started to, uncover some trends, those who were continuing to use telehealth were successful at it and found ways to get paid. Patients were happy, they were happy, it fit within their workflows, and it worked really well for them. So they continued to use it. And then those who stopped using telehealth, they had trouble with user experience. They had trouble getting paid. They had trouble fitting into their workflow. And I realized that telehealth, adoption of telehealth is not a technology problem anymore, is an education problem. And we've talked about this a couple of times where education is key. The technology is there. Now it's educating providers and organizations on how to use it. And so that's what prompted me to write the book, Telehealth Success. And I'll talk a little bit more about that as well. And then, um, and it's all about educating providers on how to be successful with telehealth. And then we acquired a company called telehealth.org that provides education around telehealth and how to use telehealth effectively. And my telehealth.org team is here. And we realize that telehealth is no longer a technology problem. It's an education, it's a workflow, it's a training problem. And we still have the technology with Doximy. It's out there, it's doing its job. Now we're building up the education arm of how do we educate providers and how to be successful with telehealth. And that's what I'm here to talk about today.
Awesome. No, that's great intro. And in fact, the lesson here is you often don't hear people's these kinds of stories, but they abound. That is that you did something small and without a whole lot of marketing and money raising, and you guys haven't raised any money literally at all. So this is all traditional bootstrapping, providing something of value, growing rapidly, and not going out of business, right? So you have a person here literally with Brandon that has done it. And like I know 10 more Brandons in other specialties that have done similarly. But the one thing that is common about all of them is they were the IC. They found the problem, they started it themselves. They didn't, I mean, Brandon went out and got programming help, right? But that's a building part of the equation. But the lesson here is that one researcher, one person with that background who thinks that there's a problem can get the solution done. And in the modern AI world, he didn't even have the AI side. But today, it's very possible if Brandon was starting it today, he wouldn't have needed that external outsourced development team, even though he did most of the prototyping and everything early on and then handed it over for implementation. That's a really, really good lesson to learn is if you've got the idea, you can actually execute on your own today. So that's great. Harshal, let's do a quick intro on you and then we'll jump into the questions.
Yeah, Brandon, great story. I love it. So I'm gonna take Brandon's stuff. I'm gonna amplify it into a clinical model that I've worked on. So I've been at Hackensack for the last 3 or 4 years, and I've worked at multiple health systems in New Jersey. And one of the key things that has kind of started and carved out over the past, let's just say since 2013, since Brandon created that solution, is that we started off with on-demand care for virtual care, right? Everyone here has used on-demand care for virtual care at some point. But now we're at the stage, on-demand is not going to work to be sustainable. What's going to work is making virtual care as part of the continuity of care for a patient. That's the important stuff, right? Because you can't just have a one-off visit and deliver care, sustainable care for a patient. Where it's going is that it's continuity of care. So where we are developing it, from my background, is a lot of patient-centric, consumer-centric focused. How do you help the patient? How do you help that single mother? How do you help that parent? How do you help patients overall deliver care in multiple modes of healthcare systems?
So Hackensack, what I like about what you guys have done is you've thought about the problem. I mean, obviously you care about the money because if it's not affordable, you can't do it. And what I don't mean is the profit side of it. It's just in order to sustain telehealth. I mean, if you use WebRTC and these technologies that are more peer-to-peer, you don't have to have massive servers, et cetera. So the tech, like Brandon said, has been solved in general. But when you're running it at a big health system like Hackensack, you still have to think about that model of sustainability of this technology, even though it's the right thing to do. And of course, in the United States, there is no business model in healthcare to do the right thing. So you got to have a proper business model. Talk about that, and what did your leadership and you guys do in terms of sustainability of this thing where other people cannot seem to find it sustainable?
Yeah, so we've stabilized it in a way where, virtual care is part of our infrastructure. It's not just an add-on service. It's part of our care delivery infrastructure, right? We can't just give a one-off like I was saying. But when we think about telehealth, clinicians are also important, right? How do we encourage and engage a clinician, right? You're not going to go to a doctor and sell technology. You're going to sell them how to remove their friction, how to help their inboxes, how to help their management of daily tasks. How are you going to use virtual care to help them? Because you're not truly selling technology. And then when you get to a patient standpoint, right, the access problem is always there. But in New Jersey, access problem is trying to get a visit with a specialist, trying to get a scheduled appointment, or someone driving from South Jersey to North Jersey. How do you remove those kinds of frictions? And that's what's important. Like, we have to develop virtual care, and any model we do, it has to touch multiple care aspects of that patient's journey.
So let's talk, this is a good conversation to have because both of you, from different angles, have said the clinician experience is probably the driving factor. It's not even the patient experience because the patient's willing to use it given other industries. So let's start from just the clinical angle. What have you guys done in terms of training, reusable assets, et cetera, to get the clinicians on board, to drive them to say, this is not something on the side. It's a core part of our care.
Yep. So, EMR integrations are key here. I think one of the things that we've helped our clinicians do is that any of our virtual care platforms that we have for remote patient monitoring, for your one-to-one visits, for your teleconsults, e-consults, we've embedded all of those workflows in our EMR.
And your EHR is what? Okay. And so all day yesterday, we heard about difficulties of integration, et cetera. So if you can dive one more deeper and tell us how you did it. And
so we work with a few partners, and one of the recent partners for remote patient monitoring, we've launched about 3,000 patients with remote patient monitoring for hypertension, type 2 diabetes, and chronic heart failure. And what the key was there is that the activity that the patients are capturing is coming directly into Epic. And where the burden from a physician is, they're not going to go into Epic and monitor continuously. We've actually hired a care team that's going to help monitor that when the patient's at home. So when a patient does come for their 3-month, 6-month, 9-month visit, they have all that data right there and a summary of that data on what happened at home. Was anything impacted? Did a medication change? Was a medication not working? And all that is right in the EMR. And when a physician is now seeing the patient in their office, they have a full picture, not just from their previous visit, but from their home, from their environment.
Nice. So Brandon, 1.5 million physicians in any circumstance.
Clinicians.
Clinicians. So describe that clinician population. So how many are mental health versus traditional primary care, et cetera, and then say, given that many clinicians, how are you going to possibly educate that variation? So let's talk about the groupings first, and then what your plan is to educate them.
Yeah, in terms of user base, it breaks down to the numbers of clinicians in the normal healthcare industry, and so about 2/3 of clinicians are mental and behavioral health, therapists, counselors, whatever. So our user base is about 2/3 mental and behavioral health, and then 1/3 more the physical health, medicine, nurses, stuff like that. And so it kind of follows what the general healthcare demographics are. In terms of educating them, a lot of the people who are still using us have figured it out, and that's why they're still using it.
Mm-hmm.
And so what we're trying to go after, we're going to educate them, but it's like, preaching to the choir a little bit. And we're going to do that. What we see is there's a lot of people a lot of providers who've used telehealth at one point because I had to at COVID, and then once in person came back, they had a choice and they said, I'm not doing this telehealth stuff anymore, and they go back to in person. Those are the people that could be doing telehealth that aren't, that probably had not a less than ideal experience that we want to help convert back into the telehealth fold. And so a lot of the stuff that we're doing with telehealth.org are going to conferences like this, provider conferences, doing CMEs online, so that when somebody wants to learn about telehealth, even though they might not be doing it, it's very easy to access. We can go to them, we can teach them how to use it, how to be successful. Again, the book is another way of getting to those providers who aren't using telehealth and educate them on how to use it effectively, how to do it well, so that they become users of telehealth again.
How have clinicians reacted on the CME side? Health Impact, just so everybody knows, is partnering with the team to help with the CME side. So tell us, was that a big benefit? Was it a side benefit that your clinicians found with the CME?
Well, so we just acquired telehealth.org, and we're essentially relaunching it. And this is one of this year's our kind of come to the market with it. But one thing that providers have to do are CMEs. And so they love the ability to learn these type of things in a very easy to consume way. And so all of our courses are online, so you can just sign up, take the course, and do it. So we want to make it super easy. It's not behind difficult sign up process or complicated paywalls and whatever. It's just like, come take the course, learn what you want, and move on. So we try to make it as simple as possible.
So quick live market research. How many of you would take a telehealth course if CME was offered and find it beneficial? I know there are providers and clinicians in the room. Anybody that would do it? There you go. You got like half a dozen at least.
How many of you are actually clinicians?
Yeah.
We got about 50% markets.
Yeah. There you go. And it is interesting that, and what's weird is that I found, just in my career, I've always thought that CMEs are a great incentive to move some behavior on clinicians, but it's rarely worked out as well as I thought it should. And so this is really good. That's why I wanted to just do a quick a show of hands, is that when you're offered the legal professional has the same thing. They have CLEs, right, as opposed to CMEs. And so for some reason, there are cases where if you have clinicians and physicians that are being offered these CMEs, they will take the course, but it doesn't impact their behavior, actually. Right. And so that's what we've got to figure out, is that could the CME be like, for example, if you continuously use telehealth all year long, you don't need to take the class anymore because you're using the damn thing, right? So this is one of those things where if we can innovate our way and say, like Lisa said yesterday, that digital exhaust is a bad word, but still, if the thing that you are doing, if you're seeing patients and you're educating them on a regular basis and you're pressing the button in the EMR, the EMR should have a report that says, you did 17 hours of this work this month, therefore, no extra CME classes needed, because the aggregation of that time has now proven that that's the case. So Harsh will talk about that kind of thing, is that the idea of just doing the work itself becomes the way that it's educating. And now they would physicians may tell other physicians, or clinicians may tell other clinicians, hey, you don't have to go do classes and stuff like that. Just use the darn thing, and now you don't have to worry about it.
Yeah, so there was a time when we were, health systems had multiple options for telehealth, right? They used their EMR to document. They had Zoom or third-party solution on another screen. That made it a challenge initially, right? And then everything merged into one. That was the key there. It made it easier because it was all in one screen. All access points were there. You can even add language interpreters. You can add guests. You can add other physicians to it. It made it easy because physicians now just had to look at that one monitor, one screen, or even maybe pull up their phone, and all of it was there. When we launched our video events, it wasn't a challenge of more training. I think providers are really willing to learn. The challenge more was how much did they retain after what they were willing to learn,
Mhm.
right? Because they were so busy, and we had maybe 10, 15 minutes with each provider to help them. So how do you expand some of that knowledge for the physician and give them their time back? So what we did was I created like a one pager across the whole network, and it literally just showed 4 pictures. Step 1, 2, 3, 4. And that made it so much easier for a physician to just look at one time. Maybe they took 30 seconds to look at it and they knew what they were doing. And everything others was intuitive. So click here, click there. Everything was within the EMR because it was their EMR. They were very familiar with it. And after that, our adoption grew. Less people started using Zoom, the third parties, they started using our Epic solution. And then when they had an issue, when they had a problem, they knew who to reach out to. I think that was a very important aspect of it. They knew the route to get a quicker answer. They knew who to contact. They knew who to ask. A lot of times they were putting a ticket in, who was it routed to? But after that, they knew who to ask, right? So they put a ticket in, we caught it immediately. We effectively gave them a white glove service, right? We needed to make sure that this physician did not have any issues, wanted to give their time back, and patient care wasn't disrupted.
Nice. Brandon, on your side, give us a little bit of profile view of which ones are succeeding with this, and is it by specialty, like you mentioned, mental health and behavioral health, which is a huge need. So talk about what's working really, really well in certain specialties, and then dwell a little bit on the idea of why it's not working for the ones that did give up. And we like to say it's not the tech, but it is the experience, right? And
Yeah.
so some of that is the tech. So talk about that.
Um, what was the question that you asked them previously?
So
I had a comment about that.
yeah, so we were talking about how if you were using technology, could the usage of the technology itself be
yeah,
the
great.
CLE?
Okay,
or
I was gonna
CME?
say, I kind of blanked for a second. So, one of the things that we've noticed is that, even though somebody's using it, it doesn't mean that they're using it right or as effectively as it could.
Mhm.
And so usage is not necessarily an indicator of success.
Okay.
And so, I mean, there are times where people are like, oh, I can't use Docs.me because it doesn't have screen share. Like, what do you mean it doesn't have screen share? It's literally right there. The word is right there. How do you not know that? And so there are a lot of things where it's just like, it's there and they could use it better. And so that's where a lot of training comes in. It's just like figuring out how much they're using and how much they're aware of certain features, and then expanding that and teaching them how to use some of those other features. And then building a little bit on a comment that you mentioned, if you don't mind, the transition to Epic. So we're talking about health systems here. So that, like, there's the health system market, and that's dominated by Epic and these large EHRs. There's a whole system of non-health system healthcare that's provided that Epic is even in the conversation. So that there's a whole different world there. But in terms of Epic, one of the there's a conversation that I had observed recently where they had, similar to your organization, where the organization moved from like Zoom or whatever it was into the Epic EHR, and the comment was like, man, we've moved over to Epic and all the providers hate it, and they're fighting us. And I've heard that story so many times that they hate the Epic experience, and everybody can relate to that if they've transitioned from something to Epic. And their solution is exactly what you said, was like, we provide white glove service. And when I heard that, I'm like, that sounds noble on the surface. Wow, we provide white glove service. This is great. But as I interpret it as like, oh my gosh, like that it's so hard to use that you have to have somebody sitting right there to walk them through how to use the product. Like, and that's not a solution, that's a problem. And I even wrote a post about this. It's gonna be published the next week, right, Maya? Do you know? Sometime, okay. But it's a whole experience that, like, okay, you can go use the Epic video solution and it's included in the price, but what's the real cost? You have to hire people to hold their hand and walk them through how to use it. Well, is it really saving money? And because the user experience is more complicated, and you have to have somebody there, and that's real money, that's real cost. But it's also, it it harms the user experience because now providers are frustrated. And if they're frustrated, they're not going to want to use telehealth. And if they're going to have a choice, they're going to be like, I'm not going to deal with this telehealth stuff. I'm going to go in person because it's easier. And so there is a true cost, even though something's free or included, there is a real cost that that is impacting usability and other downstream costs that you have to think about, especially with health systems. And so, yeah, I wanted to kind of point into that.
Mhm.
Now, what was your other
No,
question?
the other question was, so as you look at your profile of
Yeah.
clinicians that are using it, what are the factors that you see most common in success versus failure? And then we're going to let Harshal answer the question too from your side. I like.
Yeah, so this is when I was looking at, there's groups of users who are super successful using it and they love it and they rave about telehealth. And then there's groups of users who are like, I hate it. It's the worst thing ever. I never want to do it again. It's the same technology, same patients, but different outcomes. So what was that? And as you know, I turned on my researcher brain and I started asking this question. And I found that the reasons fell into 5 domains. And this is the foundation of my book, that to be successful with telehealth, you have to be successful across 5 domains. The first domain is patient success. And so patients have to have a good experience. They have to be successful with telehealth. And what does that look like? Well, it's experience. It's about access. So patients can access care, and it's easy for them to do, and that they prefer it. They would prefer to do it by video rather than coming in. So you have to be successful. The patients have to be successful in order to get them to do it. The
Just a
second,
quick note about that though. Is there a profile of the patients? Like, let's say something dumb, like if they're old, they don't like it, and if they're young, they do like it. Like that. So what does that look like?
it's what's amazing is I get some 80-year-olds who love telehealth and they hate going in person.
Uh-huh.
And then some are like, oh, I hate the technology. So there isn't really a clear breakdown.
There isn't. Okay.
And so, but what it is like there maybe some personalities are more adept to, trying things, but the, you know, age is not, it is an indicator, but not necessarily it's a black and white line, right? So, but if so, it doesn't matter the demographics, but if you can make them successful. So if you're a minority, if you're old, if you're rural, if you're urban, it doesn't matter. If as long as they're successfully getting what they need, which is care,
Mhm.
they'll be successful, and you hit that first domain. The second one is provider or clinician success. It has to work for the clinicians, and so it's got to fit into their workflow. It has to be. It doesn't add to their workload. Doesn't add to their stress. It doesn't create more of a burden on them. And so patients have to be successful. Clinicians have to be successful. It's got to really work for them. And fit into their workflow. The third is technology success, that whatever technology you pick, there's a lot of different technologies you can use for telehealth. And telehealth isn't just like a one thing. Telehealth is a broad term. So if you're doing remote patient monitoring, you need a technology for that. If you're just doing basic video calls, another technology will work fine for that. So you have to pick the right technology for the right use case. And so I spend time going through a lot of mistakes people make is that they pick the wrong technology for the use case. And so it's like they bring a tank to a knife fight. It's
Mhm.
not, you don't need that big complicated thing. You just are trying to do this one thing. Just pick the best technology for one thing. And so that's technology success. The fourth is financial success. You got to at least make money off it. You can't lose money doing telehealth. And some of the workflows and technologies people pick for the amount of volume, they're losing money at telehealth. That's not success if they're not making money or at least breaking even. So you got to make money. And then the fourth one is compliant. The fifth one is compliance success. There's a lot of rules, regulations with telehealth, cross-border licensing, reimbursement was financial, but different types of rules and regulations related to health. You have to make sure you're doing the right things and don't get into trouble with it. And so if a provider or if an organization or a provider is successful in those 5 domains, patient, clinician, technology, financial, and compliance, they will have a good experience and they will keep doing it. But if any of those fail, if you're going to be successful in 4 of them, but if the patients aren't happy, they're not going to want to do it, and then nothing else matters.
Mhm.
So you have to be successful across all those domains.
No, that's a great taxonomy there. So Harshal, if you can just tell them about the white glove remark, if you
Yeah.
want to expand on that or
So
clarify it.
I think, one of the things about white glove service, right? So any EMR, doesn't matter what it is, if you're adopting a new EMR, there's always going to be a challenge that the health system has to work through. It does not matter. I've been through about 7 of them, and it has happened multiple times. The white glove service that that telehealth that I'm working on and that I've referred to is really to make it an easy access point. So when there is a patient on the screen that they can't join, we want to make sure that the patient is able to join. We want to make sure that the physician can see the patient, whether it be through this or our backup, right? We need to make sure that the patient is connected to that provider. That's our end goal. That's what our white glove service is doing. So I think that is, and a very important aspect that Brandon mentioned is that I agree with those 5 domains, right? We have to make sure the compliance consents are captured. And in my experience at our health system, right, the initial ROI for telehealth for an E&M visit, that's one thing. But if you're expecting that to be the only thing, that's not going to work. It has to be not the first interaction, not the second, not even the third, but the subsequent interactions after 3 and 4 when they come for their CAT scan, specialist visit, X-rays that are impacting other areas of the health system. One of the things that we've kind of really focused with our patients on is building those trust, right? We initially capture them with a video visit. We initially capture them with a e-consult, a teleconsult, but we want them to return back to our health system and get the care that they need anytime they need it. So we've created that kind of virtual access area where if they call our patient access center, if they call our physicians, they know exactly what to do.
Nice. So remember, if you guys have questions, please raise your hand. Oh, there is a question. Go ahead.
There was a theme yesterday about what you'd ask of vendors that they could do more of. And I would always love to see more baked in quality metrics. And I really thought the telehealth would take like the call center and really overlay that more strongly and let you know that you had a good telehealth experience. And I don't think we've really seen that. But don't you think that would be of value, like the confidence in talking, how the cameras frame, the lighting in the room? You know, I just really thought that was going to happen, and I just really haven't seen it. I think that would be valuable.
Yeah, so we do have some of those things. So, and it's something we're expanding because we see the same thing. People want to know, how was my visit? How am I doing? And so there's some metrics we look at,
I
like
mean, from the clinician end.
from the clinician.
Yeah.
Yeah. So clinicians, you go to the analytics, and you can see, connection quality. And you can also, we have this thing called talk time. So you can know how much you're talking versus how much your patient is talking. And this is really good for counseling because as a therapist or counselor, you don't want to be talking most of the time. You want your patient talking most of the time. And so we recognize that, and we're starting to add those type of quality features in there because we see that same value. And so I'm not sure about, I don't think Zoom or Epic or anything like that.
Well, they're all doing it now. Analytics are, so there's 2 problems with analytics is the amount of analytics available in most platforms is substantial, primarily because the analytics are there as technical observability so that engineers know about reliability. So there's no lack of the data sitting there. The problem that we have is, who the hell is going to analyze that, and what are they going to do with this data after they've analyzed it? Who are they going to share it with? Does somebody's pay get cut because of it? I mean, just all kinds of crazy questions pop up. Everybody in any enterprise is being tracked up the wazoo today, right? That thanks to the pandemic and lack of belief from employers that employees were actually doing their work, et cetera, et cetera. So analytics is not the problem. Analysis of the data being captured, and this is where the AI question comes in. So Harsha, I'll let you answer her question because I know you wanted to answer it. But the follow-up there would be exactly this, which is we now have live AI capabilities to do visual models, verbal models, voice models. Verbal and voice are slightly different. And then you have these models that can be put together to give you an analysis at the end. Like you can have an automatic transcription, the sentiment analysis that I know at DocsMe you guys are doing as well. So there's a lot that can be done. The question is which parts are valuable, and there's very little research that has come out. So Harsha, I'll let you answer that question, then I'll talk to you about the AI side.
Yeah, so we do actually capture some of those analytics as well. So we do capture failures from a patient standpoint, a clinician standpoint for the connection, the length of time a patient and the physician interacted. One of the important things is, to Shahid's point, how do we actually utilize the data, right? How do we successfully utilize that data? So we take that and some of the patient feedback, some of the provider feedback, and really create some strategies to improve that interaction for a physician, whether it be to the minute detail of improving the camera itself on top of the screen or getting a better screen, better quality HD. We go in that route and actually look at technology. And that's why, as I mentioned in the beginning, it's a core kind of infrastructure for us. So any improvements we can make, it delivers that care appropriately across the board.
Yeah, and so, oh, sorry, there's a question back there. Yeah, go ahead.
Finish your thought.
We can take the question. It's okay.
I appreciate the perspective from a clinician, but what are your demographics for patients when it comes to telehealth adoptions, considering the fact that smartphone users are household income is less than $50,000 per year, and the age range or education level for a smartphone user is high school degree or below. And also, we're only looking at it from a provider standpoint, right? Telehealth implementation requires a lot of collaborative efforts from the patients, from the family. Ever thought of looking at it from a literacy perspective, or how do you determine who's qualified and who's not qualified for telehealth?
So I can
Yeah,
start.
go for it.
So when we launched our telehealth platform, so if anyone's heard of HMH 24/7, we have two options, right? You can do a video or you can interact with AI triage bot. One of the things that we also looked at is what kind of populations we would be serving in our communities, in our hospitals. We looked at all insurance type. We made it available to all insurance types. We also gave an option for a patient to call a number to help them throughout each step of that process if they need access to care. And we provided a simple phone number. We can send this phone number to everyone. It's on billboards, it's on apps. If they can download the app, it's on our website if they don't have access to the app. But we gave them that one phone number to get care when they need it. But that phone number also leads them to other care modules as well. So if they need to, I can't do virtual care, I don't have access to it, I don't have internet, we can figure out a way to do this. A lot of health systems have also looked into some of the options of connectivity in other areas, right? So how do you improve the connectivity for a patient? Creating hubs in those areas. So there are health systems that are looking at it as well. And just to Brandon's kind of comment earlier, our demographics is all age ranges, and I have actually seen over 65 and over use it more.
Did you have any comments on her question?
Does this work?
Yeah.
I haven't seen that much limit based upon patients. If you make something super simple, it makes it more accessible to more demographics. And so that's kind of our mantra. I haven't seen too many issues of limitations based upon.
Yeah, one thing that I like to remind all innovators in healthcare is the biggest mistake that you're going to make, especially for young people, is if you try to build a technology that works for every patient in every circumstance, you are doomed to failure, period. So what do you have to do? You have to say, we have to support SMS, we have to support voice, like Harshal is saying, we have to support video. And yes, not everybody can use everything, but that is no reason why you don't overcompensate and try to do multimodality, right? And that's really the important part here, is that these innovations can only come out after we test them. So you have to get it out. Sometimes you have to do things for the richest patients first because you learn on them, they pay for things, and then you make the adoptions for everyone else. Like this is what we did with SMS. Literally, SMS is probably the digital health tool of the century. That's going to be the thing that provides the most ubiquitous access. But in order to learn how to do SMS, you got to go do all the other expensive stuff first. So that's one quick lesson for everybody to know, is that the worst mistake that you can make is to say, well, I can't roll out this technology because it's not going to work for all patients. The horrible strategy to begin with. So yeah, there's one question here, one question. So somebody's got a mic already. We'll talk, we'll let you go, and then Paul, and then back over there. Go ahead.
So I'd like to go back to the idea of clinicians being resistant. In my organization, it wasn't about the technology. It was about the inability to lay hands on the patient. So I have docs who will tell me, well, I'm never going to see a patient who has a cough by telehealth because I can't listen to the lungs. And, you know, they'll say, well, I could chest x-ray, or I could have them come in for, you know, an in-person visit after the telehealth visit, but then that defeats the purpose of the telehealth visit. So clinicians are trained to lay hands on the patient and do that physical exam. How do you overcome that?
That's a 90s attitude.
Yeah, well, our mantra is that telehealth isn't going to replace in-person care. It's meant to augment in-person care. So there are things that are absolutely do it in person, but there are also things that like, okay, you really don't need to come in person for this thing, like follow-up, like that should be done with telehealth. And so I think there is this tension in some areas where it's like it's either one or the other, and I'm the biggest advocate of it's both. It's pick the modality that is best suited for what you're trying to do.
And
But you'd be surprised by what you can observe physically over telehealth. And there's a chapter in my book. My co-author is a physician, and she talks about how to do a physical exam over telehealth, and she goes through like checking the lungs, the heart rate, the whole physical exam. She goes through how to do it over telehealth, and it's really enlightening.
Yeah.
And it's just an education problem.
yeah,
Again.
what's funny about this is, and Harsha, I'll let you jump in a second, but if you think about it in the 50s and 60s, so the word tele has nothing to do with video, right? Tele means it's not here, right? That's what this term means, is that one person is here and somebody else is somewhere else over a copper wire. That's where the telehealth tele term came from. And if you read back in that same, there are papers, literally research papers saying that healthcare is going to go down the drain if patients talk to their doctors on a phone. Let's let that sink in. Today, what patients talk to doctors on phones all the time? It depends on what you're trying to do at that time, right? So if you said, I'm trying to do a televisit on a phone, that is so normal, we don't even think about it as a televisit. A phone call is just a phone call. But this, like, for example, today, there are software as a medical device, approved FDA cleared software, which can listen to a cough on a phone, and the AI will tell you what kind of cough it is, so you don't even need the imaging. And so what we've got to figure out here is, and this that's why it's brilliant for both of you to be focused on education, because I'm pretty blunt, so I'll just say it. It's bullshit to say that you can't do a analysis of a patient on a phone call, even with just humans. We have to say that now beyond humans, you have AI, you have capabilities to do telediagnostics, which is probably the best use case for telehealth is. We don't use it as much, but the best use case is probably just doing telediagnostics, learning about things that people are doing at home. And I don't actually blame any physicians or clinicians for not knowing a lot of these tools, because that's not their job. Their job is to take care of patients. But what we have to do in the community is to say, there is nothing that you cannot do with a patient that you last year had to touch them for. But this year you can use modern technology, modern capabilities, that if you are ready mentally, everything is possible. Even MRIs, et cetera. Once we have real diagnostics with ambient capabilities in the home with remote devices, it is physically possible with cleared FDA devices. I'm not even talking about this is like guesswork. This is doable today. So I know we had, did you guys want to say something there? I know we had a couple of questions. Paul, you can go, and then we'll come back to this young lady over here.
I'm with telehealth.org, and for the past 5 years, I think I've had the most unique seat to sit in, because I joined the American Telemedicine Association in January of 2020. I joined right as the pandemic hit, and ATA had been around 30 years. I had the ultimate petri dish in data collection amongst the membership that was existing and the membership that I continued to grow. And the educational component of telehealth.org is not just CME driven. It's refuting opinions from intelligent folks that say you can't do this.
Yeah.
I mean, Echo makes a stethoscope that can hear a pin drop. All right. Some of the largest health systems, okay, are forming a new ecosystem with technology solution providers that have to partner to fit into the tech stack correctly. Right? All that stuff has happened. And then we say, well, if someone's 80 years old, will they take that visit? I sat in the back of my dad's uh, bedroom where he did a telehealth visit, and he's like, "This is what it's about. This is easy." I mean, it's not challenged demographically. We have to show up though in areas where we can educate. It's not just about a visit. We got to get into the schools. K to 12 telehealth. That's food as medicine. That's telling kids not only about mental health challenges, but how they move, how they eat, how they sleep. The reason you haven't heard about this, the focus was on policy. The focus was about, GLPs, hims, hers, row. It should be about what can you do, because there's a rural transformation fund out there that, has to be spent correctly. And I think the more awareness you get, that people say, yeah, well, that's how I can take care of my wellness before I get sick. That's how I can have at-home diagnostics, at-home testing. I mean, it's all possible. And I think the education is to get clinicians to practice at the top of their license, not just professionally, but the information they put out to the patients. Because when I asked the question yesterday about data that's proliferating for hospital at home, and someone said, well, they got to determine whether it's clinical. I'm a patient. You're the clinician. You tell me if it's worthy to analyze, right? And that's what we got to get a handle on. So I think, the art of the possible is there, and I think it's just more awareness. And I'm proud to be part of it, just like I was proud to be part of ATA.
Yeah, no, and one great class would be, to the young lady's point here, is the art of the possible is the CME course itself. Like, just being able to be exposed to know that all of this is possible, that without placing hands on patients, you can know things remotely. The history, I just love history, is that if you read back on what people were complaining about with radios and phones and television, it's the exact same thing they're saying today, just with a different technology. So there's a question here as well.
Hi, good morning. Desiree, I'm a director of regulatory, so my question comes from the regulatory aspect. So I want to ask you if you have work or support any in like a consultant or subject matter expert to any government, either at the state level, federal level, and readiness for survey preparation. And my question comes because of this. Last year, we have 2 of our centers surveyed by the state OMH, Office of Mental Health. They were very, very thorough in the telehealth aspect. And they gave us a citation because we did not have a specific, in EPIC, a specific way to document the level of appropriateness of using telehealth. We have reviewed all the guidelines, the regulatory guidelines, and work with our EPIC team to ensure that we capture all that consent and all that, but not the level of appropriateness, because it wasn't clear in the guidelines. So we got a citation, another site got a citation, so we corrected it. By the third site, we passed with flying colors. Now this year, last month, we got another site, because we have 29. We got OMH arriving, and we're gonna pass our telehealth component. To our surprise, we got another citation. Now they say that we are not documenting that we ask the patient if they are in a place that they feel safe, secure, and privacy. Even though they gave us the consent and we document that, but now they want that we document that part. And that is kind of aligning with the other questions on quality assurance. So now we're gonna have to go back to our EPIC IT team and our corporate behavioral health team and say, look, in order for us to avoid another citations, we're gonna have to do an upgrade again on this. So my question is, have you guys participated in a consultant giving feedback, or at least getting that feedback so you can upgrade your platform?
So we have many folks that keep us in kind of sane reality with what is needed. When we initially launched our telehealth, we looked at all the regs, we looked at all the components of it. We have like the initial, and then we have 3 backups just in case, because we also added smart phrases in our Epic. So physician just has to put a smart phrase. We also capture the state where the patient is. The consent is very detailed to outline some of the privacy components as well. Physicians are educated that if a patient joins while driving, we cannot do that. So we are kind of doing it in tandem with a lot of things that across the board. So we are trying to do our best to keep up with our standards.
Yeah, and that was your fifth domain of compliance. So, and we've only got about 30 seconds left. If you want to summarize and then give her answer on the regulatory side, that'd be good.
Yeah, I mean, you're in a high compliance state, so you're gonna have more requirements compared to other states. But the point though of asking if you're in a safe place is a very important principle, and that's covered in some of the courses that we have, and it's covered in the book. Like, this is why you should do it, and you know, whether you have a state that requires it or not, it's still a good thing to ask and to do, because the patient might be in an abusive situation and they aren't going to fully disclose. And so it's important for providers to understand why these requirements exist, and and that's through education and what we're trying to do.
Yeah, and when you ask your IT teams going forward, what you should end up doing now is and again, we're in a post AI world. So in many of these cases, whenever you have something compliance that somebody always has to remember, the last thing you want to do is put another checkbox in. The first thing you want to do is to tell your IT guys, hey guys, God damn it, it's 2026. Can you just make sure that whenever a patient joins, this disclaimer is already said, let them acquiesce via verbal, record it, mark the transcription, summarize it in a paragraph, and drop it into the note. This is not even the art of the possible. It's like you could do it as part of your workflow today. And this is more of a challenge for you guys as complainers to IT. You have to complain. You have to be super, super opinionated about it and say, look, I don't want to hear that it's not possible, because when I go to Nano Banana and ask it to make a movie, it can make a movie. You guys can do this. Stop being lazy. Get off your asses. Put the code in so that we can continue to work with patients, because it's hard. Now, as the guy who would have gotten that call from you, it would have been nice to hear exactly what the compliance problem was, and then we could be able to solve it. But you giving us the idea that why aren't you using AI to do this is just a trigger. It reminds us, oh shit, yeah, we could have used it, but we just forgot, right? And so don't assume that the IT guys are smart, right? But they don't remember everything. And until you tell them, they're going to forget that, yeah, you could use AI to solve most of these problems today without burdening anyone. Yeah. All right, great. Let's give these guys a big round of applause.